So welcome everyone. So happy you can join us. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation, the Microscope on MDS, focusing on myelodysplastic syndromes. So in this session, Dr. Heather Leitch, a hematologist at St. Paul's Hospital in Vancouver, BC, and clinical professor in the Department of Medicine at the University of British Columbia, is here to talk about the medical and scientific work to improve outcomes and save more lives through research and treatment advances for MDS. Before we begin, I just want to take a moment to introduce myself. My name is Natasha Sani. I'm the Community Service Lead for the region of BC and Yukon. And at the Leukemia and Lymphoma Society of Canada, I'll be the moderator for today's online event. We invite you to type your questions and comments in the Q&A box of your Zoom webinar panel throughout the presentation. We'll have an LSC staff member who will be monitoring the questions, and at the end of the presentations, I will read some of your questions out loud. Due to the large number of participants and our limited time together today, we may not be able to answer all the questions. I'd also like to provide a reminder that Dr. Leitch cannot answer any specific questions about a person's health history or status. Lastly, today's presentation will be recorded and will be available to re-watch on our website. Dr. Leitch, if you wouldn't mind changing the slide for me. All right, are you looking for specific programs or resources but not sure where to find them? I want to let you know that we are here to help. You can connect with one of the community services lead in your region to receive personalized assistance and get connected to resources in your area. How can we help? Well, we can listen attentively and with compassion to the challenges you're facing, point you to information specific to your blood cancer or your treatment, help you get organized to manage and take charge of your care, and identify services that might be beneficial to you as well. Next slide, please. I invite you to visit our website at bloodcancers.ca. Our goal is to better serve our community and offer an improved experience. Next slide, please. On our website, you can find tailored information and resources, including those specific to MDS. And this includes recorded webcasts, we have podcasts, fact sheets, animated videos, and so much more. Next slide, please. Did you know that we also have a health manager app? This app is fantastic. It helps you track your symptoms, side effects, and so much more. It's easy to download and free. You can head on over to your Apple or Android app area to download, app store, sorry, to download. It helps you better manage your blood cancer diagnosis, including medication reminders. It has a meal planning section, a medication and side effect tracker. As well, you can provide access to a caregiver. Next slide, please. We also offer programs that can help connect you with other members of the blood cancer community. We offer our peer support program where you can connect one-on-one with a peer volunteer and our virtual support groups. If you're interested, you can connect with the community service lead in your area to learn more. Next slide, please. And now I'd like to take a moment to introduce our speaker today, Dr. Heather Leitch. Dr. Leitch is a hematologist at St. Paul's Hospital in Vancouver and professor at the Department of Medicine at the University of British Columbia. Her clinical and research interests includes transfusional iron overload and acquired anemias, such as myelodysplastic syndromes, and a long-standing interest in lymphoproliferative and other blood disorders in the setting of HIV infection. She is a Director of Hematology Oncology Research at St. Paul's Hospital, a reviewer of scientific papers for multiple medical journals, and a member of the UBC Department of Medicine Research Advisory Committee. Dr. Leitch, thank you for being with us here today.
Thank you, Natasha. It's a pleasure to be here. So as you saw, the title is Microscope on MDS, so I was sure to include a picture of myself with a microscope in it. I'm quite amazed at the number of participants. We just passed 83 and still climbing, so that's great. I think that there's going to be people with quite a variety of backgrounds here. So I'm going to, cover things from probably too basic for some of you to probably too advanced for some of you, but hopefully most of it will make sense. So these are my disclosures. I'm going to start very basics. So this is what I tell the medical students and medical residents. We've got MDS on the right-hand side. Blood counts are decreased. Cell morphology is abnormal. So the word dysplasia literally means that they look abnormal under the microscope. Myeloproliferative neoplasms, which are also in the myeloid space, you have normal morphology and increased blood counts. So that's the very basic difference between them. Of course, there are overlap syndromes, so everything's more complex, but that sort of gives an overview. So starting with diagnosis and classification, MDS are a spectrum of related phenotypically and genotypically similar myeloid cancers characterized by ineffective hematopoiesis in one or more myeloid lineages. So there's three main blood cell lineages: the white blood cells, the red blood cells, which carry the hemoglobin, which carries oxygen to the tissues and organs, and the platelets, which are the small cells that help the blood to clot. Morphologic dysplasia and progressive bone marrow failure occurs, leading to peripheral cytopenias. And cytogenetic or chromosome abnormalities and molecular abnormalities or gene mutations are characteristic. There's also a variable risk of progressing to acute myeloid leukemia, which is obviously an important complication. So again, in keeping with the name, we're looking down the microscope. This is a normal blood smear. So you can see the red blood cells. So they have this disc shape. They kind of look like a double frisbee stuck together. And that's why we have this area of central pallor, because they're skinnier in the middle. But they all look kind of a similar size and shape. There's a couple of white blood cells here. This is a normal lymphocyte. You can see that the nucleus is around the same size as a red blood cell. A neutrophil is a little bit bigger. This is a normal looking neutrophil with normal vacuolation and granulation. This one is not so normal. So first of all, the red blood cells are all kinds of different sizes and shapes. And in the top corner, we have a neutrophil that's hypergranulated and hypolobulated. So this is a dysplastic finding. In the bottom corner, we have another hypogranular neutrophil with hypolobulated nucleus. And this has sort of a characteristic morphology that looks like a guy with great big shades from the 70s. And it's what's referred to as a Pelger-Hewitt or Pelgeroid cell. So if you come across that term, that's what this means. So in contrast to the cells we saw before, this is a myeloid blast cell. So this is what we refer to as number of blasts in the marrow. In this case, we're in the peripheral blood. And look how huge it is compared to the red blood cells. It's huge. It's got big open chromatin, very busy nucleus. So the cell's very, metabolically active. There's large nucleoli. And this one has a characteristic finding in acute myeloid leukemia called Auer rods. So you can have acute leukemia without Auer rods, but if you see Auer rods, that is a leukemic finding. Predisposing factors unknown in the large majority of patients: older age, like everything in medicine, male gender, like most things in medicine, and secondary to particularly some classes of chemotherapy and certainly ionizing radiation. So if we see a patient who's been treated for another cancer with chemo or radiation, I would have a lower threshold for doing a bone marrow biopsy in this person. Chemicals and immunosuppressants, there may be a link. It's less well defined than the other two risk factors. This is the age-related incidence in the general population. And so this is kind of where the baby boomers were 10 years ago. This is where they are now. You can see the incidence has very much increased. The prevalence has also increased as we get better at keeping patients alive longer. So does the incidence truly drop in the 85 and 90-year-olds? Probably not. Probably people are just less likely to do invasive investigations in people who might have other significant health problems and clinical frailty. So the median age of onset of MDS in the Canadian population is around 70. It is, a hematologic malignancy, of course. It's a blood cancer. In 84% of lower risk patients, the cause of death is related to MDS. So we obviously need to do something about that. When we make treatments in decisions in MDS, we take into account disease-related factors such as the number of cytopenias, how many of those cell lines are low, the number of blasts in the bone marrow, and the chromosome analysis or karyotype. And these feed into the predictive scores for treatment, for predicting treatment outcomes. But also we need to take into account patient-related factors such as age, comorbidities, and a big one in Canada is distance from the treating center. And I'll talk about patient-related factors a little more later. One of the things that is kind of confusing about MDS for people is that the classification systems keep changing as knowledge advances. So I'm not going to go through all of these in detail, but back in the 1980s, we had the FAB or French American British classification. So FAB, I think, was appropriate to the era. Dr. John Bennett is now in his 90s and still coming to the meetings and saying brilliant things. 1997, we had the International Prognostic Scoring System, which has been updated several times. The World Health Organization classification in 2001, several different scoring systems, the WHO update, the IPSS revised is important. There's a cytogenetic scoring system, another WHO update, the MDS CAN, which I'll talk about more. The molecular IPSS is very important. And in 2022, we had WHO and international consensus criteria classifications. In the future, things that will likely be taken into account as affecting prognosis include microRNAs, epigenetic changes, circular RNA, inflammasome, and machine learning models. So when we diagnose MDS, the initial workup includes peripheral blood work and bone marrow testing, and we want to exclude other causes of cytopenias. Anemia is the most common cytopenia in MDS, thrombocytopenia and neutropenia in about half of patients, but really the most clinically relevant cytopenia is anemia. So obviously we would meet the patient, do an assessment, do blood tests, do a bone marrow biopsy, and do cytogenetic and mutation testing. So these are the three most commonly used now classification systems, the WHO 2016, the WHO 2022, and the ICC. And you can see how they relate to each other. I'm not going to get into the details. That's for the hematopathologist. And here's some more. So you can see that it's getting kind of complicated. And so all these classification systems are a bit of a moving target. I'm just going to talk about a couple of MDS subtypes because it does have treatment implications. So there's a subtype associated with deletion of 5q or the long arm of chromosome 5. It's one of the most recurrent cytogenetic aberrations in MDS, and it accounts for about 10% of primary MDS. The importance is that lenalidomide treatment is very effective at reducing transfusion requirements and even eliminating them completely with a median duration of reduction in transfusion requirements of up to 3 years. And some patients obviously have a response that lasts longer. So 5q minus syndrome is the sole cytogenetic abnormality. There's not any other chromosome findings. Female predominance, indolent course, favorable prognosis, about 15% transformation to AML over time, and a median survival that's long for MDS over 5 years. This is a normal bone marrow aspirate, and you can see there's a number of different cell types in the bone marrow. I don't expect you to identify them, but I'll point out this is a plasma cell that forms antibodies. These are some neutrophil precursors. This is what we call a megakaryocyte, which is the cell that forms platelets. And so see how much bigger it is than the other cells. I've done this one to about the same magnification, and these are the megakaryocytes. So this is a characteristic finding in the 5q minus syndrome. This is what we call a micromegakaryocyte, which is my favorite word in hematology. It translates literally to little big cell. Ring sideroblast and the SF3B1 mutation. SF3B1 is a component of the spliceosome, which is involved in taking RNA that's transcribed from DNA and forming it and processing it so it forms messenger RNA, which then goes and makes proteins. And so this mutation exists in about 90% of patients with MDS with ring sideroblast single lineage dysplasia and 70% with multilineage dysplasia. What it refers to is this is a bone marrow slide stained for iron. These are immature red blood cells. You remember the ones we saw before, like here in the background, have extruded their nucleus before they're released into the bloodstream. And the blue dots that you can see are deposits of iron in the mitochondria, the powerhouse of the cell, which rings the nucleus. And so that's why they're called ring sideroblasts. The link between ring sideroblasts and SF3B1 mutation does correlate with a favorable prognosis, and it doesn't really matter how many ring sideroblasts you have. So prognosis, there's multiple scoring systems. The IPSS and IPSS-R are still the most commonly used. Recently, the IPSS-M was developed, which includes integrates somatic mutation data. And so I'm not going to go through this in detail, but you can see there's a number of criteria, how many blasts in the marrow, differences through the three systems, what's the karyotype abnormality, some of them portend better or worse prognosis, how many cytopenias, how deep are the cytopenias, and so on. This is how the three scores relate to each other. So for management purposes, we divide patient groups into lower risk and higher risk. And this gets, the IPSS-M does away with the awkward split between the intermediate group to categorize in lower and higher risk. I want to talk about IPSS-M for a little bit because I think it's very important. This is done by the International Working Group for the Prognosis of MDS. And so they had what they called a discovery cohort of just under 3,000 patients, and then a validation cohort of just under 800. These are the mutations that occur in MDS. You can see that there's a lot of different ones, and they occur in variable frequencies. They found that 48 genes were mutated in more than 1% of patients. 94% of patients had at least one somatic mutation. The median was 4 mutations per patient and range up to 20. So they looked at an association between each mutation and clinical endpoints, including leukemia-free, overall survival, and AML transformation. They adjusted for baseline characteristics, age, sex, MDS type, primary versus therapy-related, and IPSS-R score, and found 14, 16, and 15 genes were significantly associated with adverse outcomes. They kept the IPSS-R cytogenetic categories. And then they did a multivariate analysis with the adjustment for the confounders and came up with this crazy looking formula, which I am not able to do in my head, translated to this curve, which they divided into 6 risk categories: very low, low, moderate, high, high, and very high. This is what these are this leukemia-free and overall survival curves from very low to very high. You can see there's a nice separation of the curves. This score also does better at predicting the outcome of therapy-related MDS. So previously, if we were using the IPSS-R, we would get the risk score and just know that someone with therapy-related MDS was going to do worse than that score would predict. So this is what the web calculator looks like. You first input the data, the bone marrow blast, the hemoglobin, the platelets, and so on, and then the cytogenetic categories, and then, each mutation, yes or no, yes or no, yes or no, and it comes up with a score, and it actually has an arrow that points to where you are on that curve and says your median overall survival is this, and your percent chance of progressing to AML at 1 year is this. So I think that this is really a very helpful score. And I just wanted to turn to the MDS-CAN MDS patient registry. So many of you are probably familiar with this. It was started in 2007 at Sunnybrook Hospital by Dr. Rena Buckstein and her colleagues. It went national in 2012, and it consists of patients filling out questionnaires every 6 months and undergoing small tests of physical function yearly. How fast can you walk 4 meters? How fast can you stand and sit 10 times? And the hand grip strength. It prospectively collects data on MDS, but also with a clinical frailty score, the Charlson Comorbidity Index, the MDS-specific comorbidity index, and the Lawton-Brody disability score. And we've had a number of very helpful analyses that have come out of this, and I'm going to show you a couple of them. So this was an early analysis, and we found that what was significant was the IPSSR, the frailty score, and the Charlson Comorbidity Index, and broke down patients, assigned weights, and they broke down into 3 groups. And you can see quite a separation of the curves from low to high risk. And I think the importance of this score is every other prognostic score, of which we have many, takes into account disease-related factors, like I said, number of blasts, number of cytopenias, and so on. And we all know that patients with other medical conditions that are frail and so on are going to do worse, but this is the only score at that time and to this day that actually starts to quantify that effect. So what about anemia and management in lower risk MDS? MDS is strongly associated with transfusion dependence. This is the IPSS score. Low risk patients, 40% are transfusion dependent, high risk patients, 80%. And not only does transfusion dependence impact significantly on quality of life, people feel coming up to their next transfusion, they have to go in for their cross match, and then the next day for the transfusion. If you're coming to St. Paul's, you have to, pay $30 for parking and step over the street people to get to the, transfusion unit and so on. But also, it is associated with clinical outcomes. So this is an analysis from Luca Malcavati and colleagues in Pavia, Italy, over a decade ago now, almost 2 decades ago, 2006. So this is overall survival according to patients needing 0 units per 4 weeks, then 1, 2, 3, 4. You see that stepwise decrease in survival with a stepwise decrease in leukemia-free survival on the right. This has been replicated by the European Leukemia Net MDS registry. So transfusion independent patients, those with a low transfusion density, and those with a high transfusion density. So their cutoff was less than 1 unit per month, but already you can see that association with progression-free survival. So therapeutic objectives for MDS patients. In lower risk MDS, we want to reduce and hopefully eliminate, at least for time, transfusion requirements, improve quality of life. And in higher risk MDS, we want to do both those things, but also extend overall survival, delay AML progression, and alter the disease's natural history. Obviously, we'd like to do that in low risk patients as well, but I'm not sure that we're there yet. You can see that this is a long list of potential treatment options for lower risk MDS and some for higher risk MDS. In reality, our treatment options are more limited, excuse me, to erythropoiesis stimulating agents, things like erythropoietin or darbepoetin, supportive care for lower risk MDS, and hypomethylating agents with or without other agents for higher risk MDS. So we need better treatments, we need newer treatments, and there are always clinical trials going on. Unfortunately, a number of them have been negative. ESAs are common first-line therapy for symptomatic anemia. They don't have an impact on AML progression, but receiving an ESA is an independent favorable prognostic factor for survival. The response rate is around 50%. Responses last from 18 to 24 months. I've actually had patients who responded for several years, and sometimes we add GCSF. That's kind of the fine print. There are several scores for predicting response. This is from Dr. Valeria Santini in Florence, Italy. Serum EPO level, serum ferritin level, IPSSR score, and it gives you variable chances of responding. This is a combined Canadian and Italian risk score, transfusion dependence, EPO level, and IPSS low risk. So we do take those things into account, particularly in provinces where the EPO has to be paid for by patient's private insurance. This is just to show you that we do have criteria for lack of response and also criteria for loss of response. The details aren't really important to this discussion. So what if we just have transfusions? So we do have complications of transfusions. Transfusion reactions, alloimmunization, and infections really don't occur commonly, but they can occur. The main one that we worry about is iron overload. And we worry about it especially if we're me, because that's kind of my thing. So we saw the survival curves previously, inferior overall and progression-free survival when they're transfusion dependent. And in the EU MDS analysis, they found that in non-transfused patients, the MDS-related cause of death was 28%, 39% in low transfusion, and 48% in high transfusion. So inversely correlated with progression-free survival, even at a low density. We can use iron chelation therapy to take away iron. So the problem with iron is there's lots of iron in transfused blood from the transfused red blood cells, but the body has no way to get rid of excess iron, which is probably an evolutionary mechanism that we can discuss at some other point in the future. Using medications called iron chelation therapy, we can have an impact on iron overload. This was a randomized controlled trial of an oral chelator called deferoxarox versus placebo and lower risk MDS. And you can see there were problems with this trial. It accrued slowly. The population was decreased by 2/3. Half of placebo patients quit the trial and went on to receive iron chelation. And despite this, we still saw a difference in overall, event-free survival favoring chelation patients. So I think that in real life, the difference that you might get might well be greater. This is again from the MDS CAN registry. These are the kind of very useful analyses we can get. So we found in all MDS patients, those who received iron chelation therapy had better overall survival than those that did not. We did several matched pair analyses, removing patients thought to portend better or worse prognosis. And in 7 out of 8, we still saw better overall survival in those receiving chelation. We do have Canadian guidelines for the management of iron overload, which were published in 2018. So what about after you've received ESA and are no longer responding? We do have now an erythroid maturation agent, or an EMA, called luspatercept. We unfortunately don't have funding for it in British Columbia, but the other provinces do. There's also combination therapy with decitabine, cedazuridine. Decitabine is a hypomethylating agent. Cedazuridine is something that prevents it from being broken down in the GI tract. So it's an oral therapy that is indicated for not only higher risk, but also IPSS intermediate 1, which is a lower risk subtype. So luspatercept, the EMA, this is transfusion dependent from very low to intermediate IPSS-R risk MDS with ring sideroblasts or SF3B1 mutation, have failed or are not suitable for EPO-based therapy. And you can see that the percentage of patients who achieve transfusion independence was higher in the luspatercept group than in the placebo group. It does have side effects. These are the ones that occur: fatigue, diarrhea, nausea, dizziness, and so on. Many patients tolerate it very well. Others tolerate it not so well at all. So it's a matter of sort of trying and seeing. DEC, as I said, is indicated for patients with intermediate 1 to high risk IPSS group. I personally have to have a very good reason to treat an INT1 patient with DEC because it is a hypomethylating agent, which we use in higher risk MDS. Once you've progressed on a hypomethylating agent, the options for treatment are few and far between. So what do we do for a patient when they do progress to higher risk? So I'm not going to go through all of this. This is what I was telling you about breakdown in the GI tract. So what does hypomethylating agent mean? So in the promoters of genes, we have methyl groups attached, and that causes the gene downstream to not be expressed. So azacitidine or decitabine are hypomethylating. They remove these methyl groups, and then that gene can be expressed. And which genes are important? Many years after the onset of having azacitidine, we still don't have a good sense of this. There was a trial done with DEC comparing the pharmacokinetics and pharmacodynamics between the oral formulation and the IV formulation. They got 99% overlap, so we do know it's equivalent to IV. Upcoming treatment options that, show some promise. Imetelstat, which is a telomerase inhibitor, the telomeres being the ends of the chromosomes. And if they're breaking down and getting shorter, that causes the cell to die. So this inhibits the enzyme, the telomerase that does that. It has been actually approved in the US as of June by the Food and Drug Administration. Usually Health Canada is about a year behind the FDA. What about higher risk MDS? So this is a very important trial. This was published in 2009 by Pierre Finot, who's the head of the Group Francophone de Myelodysplastic, or GFM, based in Paris, France. And it compares azacitidine versus conventional care regimens. And so what that means is they had 3 different groups of patients. So if I'm looking at a patient, I'm like, okay, you are fit enough to receive AML chemotherapy. You're appropriate for low dose chemotherapy. You're appropriate for supportive care. The patient goes into that pot, and then they're randomized between whatever and azacitidine. They actually saw an improvement in survival in all the subgroups, not only as I've described, but the different subgroups by response to therapy. The only patients that didn't have a survival benefit were people who progressed on azacitidine. And this is the first therapy in higher risk MDS that's been shown to improve survival. So it's a big deal, and it's still our standard therapy for higher risk MDS. There have been several clinical trials done adding on other agents, magrolimab, sabatolimab, and unfortunately those have been negative, but we don't stop trying. I did want to bring to your attention the MDS ClearPath, which is an online algorithm developed by the Canadian Consortium for MDS, or CCMDS, and I should have put that in my bio that Natasha read. So you can see how many hematologists from across the country were involved in developing this. It is available in English and French. The first version went online in 2013, and we continue to do updates. There is a new update that just went live at the end of 2022. This is the home screen. I've passed over the one where you choose English or French, and I've also passed over the one where you can go to the classic version and the new version. And the new version looks a little different. Why that is so that it can fit on your phone. So there's 2 modes. You can go to the self-directed, the full algorithm, which is generally, those of us who do MDS for a living. But there's also a treatment wizard, which is a step-by-step series of questions that take you to a treatment decision. I'm not going to go through all those steps, but I'm going to show you some highlights to see what kind of information we have. So the ClearPath has been accessed in 120 countries around the world, and the app has been downloaded in 34 countries. And I regularly have colleagues say to me, could we have it in Spanish? Could we have it in German? Could we have it in Japanese? And in fact, a few years ago, I was, kind of zooming around to different countries talking about iron overload and MDS. And I would tell the conference organizer, you have to give me 20 minutes to show them the MDS ClearPath app. And my experience was that the physicians and other healthcare providers in the audience would be downloading the app as I was speaking. So people find this really very useful. So we're going to go through a case. This is a patient of a colleague who his name is Vera Pale because she's anemic, 74-year-old woman, otherwise well, transfusion independent, but she is tired and short of breath on exertion. Her hemoglobin is 88 in our units, white cells, neutrophil count, platelets. The MCV, mean cellular volume, is high, so she's macrocytic. We do some other stuff to rule things in and rule things out, and what further investigations are indicated. So we do a bone marrow biopsy, which shows trilineage dysplasia. So it means that all 3 of the main cell lines look abnormal under the microscope. 2% blasts, 15% ring sideroblasts. And so here's the different classifications, in the updates. She has a deletion of the long arm of chromosome 20. I'm sorry about the background noise. That's an ambulance outside. Her karyotype is good risk, and she also has an SF3B1 mutation, which is also good risk. So here's her EPO level. And so what are the risk scores? I haven't shown you, but we have a calculator. Oh, actually, it might be in here a little later. So no, I don't think it is. So there's a calculator on the website with just drop down menu that you enter the information and up come your risk scores. She's low risk in the IPSS, the IPSSR, and the IPSS-M. So what management is recommended? So she starts transfusions, and so she doesn't want to do that. And so we start EPO at 40,000 units per week, which is the usual starting dose. After 8 weeks, her hemoglobin is just 86, so we go up to 60,000, which is the usual dose increase. And after 12 weeks, her hemoglobin is 109, and she doesn't have symptoms anymore. So she's transfusion independent. She remains transfusion independent for 1 year until the counts decrease and she becomes transfusion dependent again. We do a repeat bone marrow biopsy. Why? Because she's had a clinical change. So we want to know if she's progressed to higher risk MDS in order to help her appropriately. So she's still lower risk. So should we continue ESA therapy? Obviously not. She's not responding to it. Just to show you that we have recommendations about initial dosing and dose increase and so on. We also have information on response criteria, responses that you expect, side effects, and also provincial reimbursement. And if we go to the overall algorithm, it highlights the path that we've taken to this point. And so we're going to move on to second line therapy with luspatercept because she has an SF3B1 mutation. So after 5 doses, she becomes transfusion independent, her hemoglobin improves, and so everything's good. So this shows you the kind of information that's also on the algorithm. We have the same kind of information individualized to each treatment for every medication. Recommendations for dose increase and decreases. I think this is very important information. It came out of the most recent American Society of Hematology. It does show you that patients who achieve transfusion independence have better overall survival than those that did not. So I think that's important information. They do have data from another trial with luspatercept showing an improvement in patients' quality of life. I mean, as I've said, this applies to some people, but not everyone can tolerate luspatercept. So, she maintains a response for 10 months and then she becomes transfusion independent. And she is still lower risk. So what do we do now? So she's an intermediate 1 IPSS patient. So we consider her for DEC therapy with the caveats that I already mentioned, and she becomes transfusion independent again. Again, we have the same kind of information for decitabine cytisuridine and also IV decitabine as well. So she loses her response. And what are her options now? So consider enrolling patients in a clinical trial. That's very important when we have so few medications, and also supportive care. So pain, other symptoms, infections, and quality of life. We also have on the Clear Path information on acquired predisposing conditions. So you may have heard of ICUS or idiopathic cytopenia of undetermined significance, CHIP or ARCH, clonal hematopoiesis of indeterminate potential, or otherwise called age-related clonal hematopoiesis, and CCUS or clonal cytopenia of undetermined significance. IDUS we don't talk about very often, but we also have information on investigating familial predisposing conditions, how to do that and when to do that. So the ClearPath, I just type MDS ClearPath into my browser and it comes up. Or you can download the app in English or French through the Apple App Store or on the website or from this QR code. And it's the very high price of free. I had kind of an aha moment in 2014 at the Canadian conference on MDS, which was in Banff that year. That's neither here nor there, but we had Pierre Finot there, the head of the GFM. We had to book him about 10 years in advance, but he was very excited about this. He ran up to me after the presentation, told me he'd already emailed the link to his nurse. And so, you know, I kind of thought, well, if Pierre Finot likes it, it must be useful. We've developed a similar algorithm for the management of iron overload called the MDS Iron Road. Why? Several reasons. First of all, I've got a train engine in the background here. The Canadian Railroad is a big deal, as many of you know. And also the Italian word for railroad is ferrovia, which means literally iron road. This also is available in English and French. And, you know, you guys, unlike many of my residents, are old enough to remember Gordon Lightfoot and his Canadian Railroad trilogy, and the line that says they looked in the future and what did they see? They saw an iron road running from the sea to the sea. So that was part of the inspiration. This is the driving of the last spike, which happened at Craigellachie, BC, which is just outside Revelstoke. And the National Railroad was a great big part of the deal that brought British Columbia into Canadian Federation, so it's kind of a Canadian moment. Like the MDS ClearPath, we have an overall algorithm. So lower risk MDS, information on what that means, higher risk information, assess for transplant eligibility. Are they transfusion dependent? What does that mean? Do they have documented iron overload? What does that mean? If not, monitor information on how to do that. If yes, reduce iron overload, preferably by inducing transfusion independence with MDS treatment. If you can do that, information on phlebotomy, reducing iron overload, and if you can't, information on chelation. There's copious information on iron overload in the usual clinical setting, and also in the transplant setting. We also have levels of evidence, grades of recommendations, future directions, and references. So as a healthcare provider, I find this helpful to have all that information in one place. Why is iron toxic? This is depicting the usual what we find usually in non-iron overloaded patients. So this square represents transferrin, which is the protein in the blood that carries iron and renders it non-toxic. Usually transferrin is about 30% saturated. Once it becomes saturated by transfusion, we have non-transferrin bound iron. A subset of this is labeled plasma iron, which is redox active. It can deposit into the tissues and organs, notably the liver and the heart, but also the bone marrow, worsening bone marrow failure. But because of the ability of iron to transfer electrons, it can undergo a Fenton reaction and form oxygen-free radicals, or reactive oxygen species, which have been shown in multiple studies to damage lipids, proteins, and nucleic acids. So you can imagine that could have consequences for cells. So what we have in terms of clinical information from the EU MDS registry, the patients with the best survival had undetectable LPI and were transfusion independent. The ones with the worst survival were transfusion dependent and had detectable LPI, and the other groups were in between. So LPI aren't that hard to measure, but we don't have assays that are standardized in clinical laboratories. Before I tell you that, we're going to get the advanced cell biology. So this is the hematopoietic stem cell and some of the things that are going on. So the NTBI receptor is taking up iron in an unregulated manner, expanding the labile iron pool, having effects on the mitochondria, the powerhouse of the cell, having effects on the cell cycle, affecting respiration. Caspases are stuff that mediates cell death. We've got DNA mutations leading to cell death or AML progression, effects on the lipids, which can alter membranes and result in cell and organelle lysis. And we also have an alteration in the number of granulocytes and macrophages that are produced as opposed to erythroid cells, further exacerbating anemia. This is more specific things that happen in the stem cell. So again, we have fragments of DNA moving from the mitochondria to the cytoplasm, where they affect the NLPR3 inflammasome, which is thought to be central to some of the key features of MDS, impairing hematopoiesis. We have effects on the VEGF promoter. We have effects on phosphatases, which alter kinase activity, which alters cell signaling. We have effects on proteasomes, which kind of degrade the aged proteins in the cells. We also have effects on the cell ability to interact with mesenchymal stromal cells, which support their growth and viability. In the heart, we have three differences. First of all, we have 3 NTBI receptors. We have lots of mitochondria. The heart cells need lots of energy. And we also have myofibrils, which mediate contractility. The heart obviously needs to contract. So we have all this excess iron coming in. It's trashing the mitochondria. It's doing all the usual things, and it's also damaging the myofibrils. So you can imagine that can have difficult effects on cardiac cells. And so this is from a review that I published with a very talented student, and those of you who are cell biology nerds like me can look it up and read further. Bottom line, labeled plasma iron appear at a transferrin saturation above 80%. Because we can't readily measure LPI, we looked at the MDS-CAN registry to see what happens when your transferrin saturation is over 80%. And sure enough, they have inferior overall survival and also inferior cardiac death-free survival. So some of that theoretical stuff that I showed you in the cardiac cells is probably having an effect in the clinic. This is the most recent thing that I'm working on. And so it's a very busy slide. Underneath you have sort of MDS progression and how it interacts with cytokine release and, immune effects and mutations and so on, how iron affects some of those steps, and how the specific mutations that we see in MDS interact with iron overload and MDS to cause MDS to be better or worse. So finishing with some general comments on iron overload, I'm turning online to a couple of online articles, one called Iron is the New Cholesterol. It talks about how iron is central to many processes and disorders. There's an abbreviated quote, such as the Faustian bargain that has been struck by life on this planet. Oxygen and iron are essential for energy production, but may also conspire to destroy the delicate order of our cells. Life was designed to exist at the very interface between iron sufficiency and deficiency. And this is really fascinating, how iron is an ancient signaling molecule. It's actually not a molecule, it's an atom, but that's neither here nor there. It talks about how iron was involved in signaling billions of years before the existence of adenosine triphosphate, or ATP, which we think of as the energy source for the cell. Environmental conditions and porous hydrothermal vents where heated mineral-laden seawater spews from cracks in the ocean crust created a gradient and positively charged protons that served as a battery to fuel the creation of organic molecules and protocells. So here we've got the heated mineral-laden water. You can see how that could set up a gradient, and that's allowing the formation of proteins, lipids, nucleic acids, protocells, and evolving into cells. So without iron, we might not actually have life on this planet. So it's pretty important. I borrowed this from the Thalassemia International Federation. They say keep calm and chelate. I'd say keep calm and reduce transfusion requirements whenever you can. So to summarize, there's significant advances made in the understanding of MDS cellular biology, which has led to new classification systems. For several years, these advances have not translated to lots of new treatments, though we now have luspatercept and DEX-C. Incorporation of mutations into the IPSS-M have refined prognostication. Further refinements in prognosis are expected with future advances, and the MDS clear path has been updated to reflect progress in MDS. The MDS Iron Road is now available for management of iron overload. Happy to take questions. That's the end of my presentation.
Thank you so much, Dr. Leitch, for sharing your expertise and insight with all of us today. So it is now time for our Q&A period. So if you haven't done so already, You can pop into your Zoom webinar panel and type your questions in the Q&A box. As mentioned earlier, we may not be able to answer all questions, and Dr. Leitch cannot answer any specific questions about a person's health history or status. So for our first question, Dr. Leitch, what are the best health practices for early stage MDSU?
Yeah, so that's a really good question. And this is something that, I tell my patients when I first tell them that they've got MDS. First of all, I give them printed information from the Leukemia and Lymphoma Society. They find that really helpful. So thank you for that. But I do tell them that there are no dietary or lifestyle factors that brought this on. There's no dietary or lifestyle factors that will make it better. But I really encourage people to endorse the usual health maintenance procedures, the things we all should be doing. Stop smoking. And if you're not a smoker, don't start now. Regular, healthy, balanced diet, get enough sleep, get some exercise, listen to your body, don't overdo it, and check in with your healthcare providers regularly.
Awesome, thank you. We have a question from before. Will a gradually increasing MCV lead to a blood cancer with no other indications for MCV increase?
Right. So the MCV can be increased for a number of reasons that are not all related to blood cancers. It can be related to liver disease, for example. I'm not saying you have liver disease, but it can also be related to thyroid disorders, also deficiency of some vitamins. So it's really an increased MCV with also anemia that we get more suspicious of. It's possible that it may be related to some of those pre-MDS conditions, the chip and the arch and that so on. We're really not able to investigate for that. It requires, an analysis for somatic mutations. And, we actually have to sort of negotiate even to get that for the majority of our MDS patients. So we have to prioritize just because it is an expensive test. And I think that the other point about that is with the predisposing conditions, we know that some people go on to develop a hematopoietic neoplasm, not necessarily MDS, some others as well, but we don't know how many do. It's probably a small proportion, and we don't know which people those are. So once we have more information on that, those points, then we will probably have a better ability to do these investigations.
Okay, and then I guess in keeping with that, is MDS, can it be hereditary?
Rarely. So
Rarely.
rarely there can be an inherited predisposing condition. So you don't actually inherit the MDS, but you could inherit a mutation that predisposes the bone marrow to form MDS. And so we do have, information on under what circumstances to work people up for hereditary mutation. But the vast majority of my patients, I say that up front. It's not something that you inherited. Your children, grandchildren are not at increased risk compared to the general population. You didn't inherit it from your parents. So rarely hereditary.
I'm going to just check here. How can the environmental exposure affect, for example, working in a manufacturing plant, for example? So I guess,
Right.
is there any environmental exposure element for the onset of it?
That's another great question. And unfortunately, we don't have enough information on that to be able to answer it well. I mean, with all the things we're exposed to over a lifetime, you have to think that there are some things that might predispose to one thing or another, but we just don't have the kind of population data to really, say that this is definitely a link, other than for certain classes of chemotherapy and for ionizing radiation, for other cancers or other conditions. Sometimes people get chemotherapy for non-malignant conditions as well.
Okay. And we have another question here. Is the SF3B1 mutation found in all MDS patients displaying ring sideroblasts?
Ring sideroblasts. There's a lot of overlap. It's not 100% overlap, but most ring sideroblast patients do have SF3B1 mutation.
Okay.
There are some other spliceosome mutations, so that could lead to ring sideroblast formation as well.
And then another question here, is X-Jade an effective for managing iron overload?
Yeah, so X-Jade is one of the oral iron chelators. It's deferocerox, which I showed you some curves on. It's also, so that's the original formulation. There's also a tablet formulation called Jade-Nu. This is an effective iron chelator. It's absolutely effective. It's, iron chelation can be tricky. So it can have side effects. It can have sort of GI side effects. The one that usually limits the dose that we can use in clinical practice is it can, cause the kidneys to not function as well as they should. Obviously, the kidneys are very important, so that often limits our dose. People can have other side effects as well, such as mouth sores and so on. But it is a very effective medication, and I think it's more practical than the other options that we have in that it's taken by mouth once per day, as opposed to the classical iron chelators, deferoxamine, which has a short half-life, so it's given by continuous infusion under the skin for at least 12 hours per day, at least 5 days per week. So that's obviously inconvenient. And then the third chelator is sometimes used in MDS, but is not really approved for that indication because it can affect neutropenia, and it's also taken 3 times per day, also has GI side effects and other side effects as well. So we do need better chelators, but we also need to really focus on limiting iron overload too by, improving, decreasing transfusion requirements.
Thank you. And then I have a treatment related question. Do you know if there's been development to treat MDS or AML via CAR T cell treatment?
Right, that's a great question. I'm so happy to have a cell biology nerd like me in the audience. People are working on it. It hasn't reached prime time yet. I actually, gosh, it was under a year ago. It seems like longer now, but I went to a fantastic meeting on myeloid disorders put on by the European Hematology Association. There's a guy in Oxford who's working on dendritic cell therapy for myeloid disorders. So this is very early. It's all preclinical, but yeah, people are looking at it.
Yeah. Awesome. And then is there I guess a marker for when you would start transfusions?
Yeah, that's another good question. It really varies from patient to patient. So some people, develop symptoms if their hemoglobin is less than 90, others are fine to less than 80. But we kind of individualize it to our patients. If you're late 80s, I use a higher transfusion threshold than if you were sort of late 60s, because your lungs and your heart are older and the anemia is going to put a strain on them. So it is something that there's not kind of an easy answer to. I'd say generally a hemoglobin less than 90, but it really depends on how well or not the patient is tolerating the anemia, which is quite variable from patient to patient.
Well, thank you. I think that's all the time we have for questions today. Again, thank you so much, Dr. Leitch, for your time. Your expertise in this presentation was extremely valuable for us. I'd also like to just take a few minutes to wrap up. Dr. Leitch, if you wouldn't mind flipping the slide for me.
Oh.
One more time, thank you. We'd also like to send a big thank you to Bristol Myers Squibb for their support in making this event possible. Next slide, please. And we'd also like to invite you all to our next event. This is going to be on August 14th from 4 to 5 p.m. Eastern Standard Time. Topic, a deep dive into diffuse large B cell. You can scan the QR code here on the slide or visit bloodcancers.ca/events to register. Next slide, please. We'd also like to invite you to join us for our National Leukemia Conference. This will be our 3rd edition. It will be held between November 4th and 8th 2024. Again, you can scan the QR code there on the slide, or you can visit our website, bloodcancers.ca/leukemia conference for the details and to register. And then the next slide. And just a reminder that we are here to help you. You can reach out to us by email, by visiting our website, bloodcancers.ca, or by calling us toll free. Also, please note that a short survey will be sent to all participants today after the presentation. Please take a few minutes to respond, as it really does help us plan for future events. Thank you all for being with us here today, and take good care of yourself. Bye for now.